Hi guys, my name is Dello and we are on our third video lecture for pneumothorax, and from our previous video we stopped at the laboratory information, so we're starting from here. So in this information we only have two. We have the ABGs, so arterial blood gas. So ABG for acute pneumothorax and for large pneumothorax. So for acute pneumothorax we have acute respiratory alkalosis because the pH increases, carbon dioxide decreases, PO2 decreases, bicarbonate decreases, and our saturation decreases. It's respiratory alkalosis because we are trying to blow off more CO2, so it gets more alkalotic because when pH decreases and CO2 decreases, that means the acid is decreasing because CO2 is considered as acid. And our pH also increases. So our pH, when it's low, it's acid. When it's high, it's alkalosis. So that explains to us that it's respiratory alkalosis because our CO2 is more alkalotic and our pH is more alkalotic. For large pneumothorax, it's going to be acute respiratory acidosis because our pH will decrease, our CO2 will increase, PO2 will decrease, bicarbonate will increase, and saturations will increase. Saturations will decrease. So pH will decrease because we are retaining more of the CO2. CO2 is increasing. So there's more acid on our body because we are continuously creating carbonic acid rather than creating bicarbonate and hydrogen ion. Excuse me. And our bicarbonate will increase too, but it will not take any much of an effect yet because our kidneys takes way too long to compensate. So it takes a couple of days to compensate. So it'll be a couple of days of respiratory acidosis before the increase in bicarbonate will take effect because of the kidneys, because it's retaining it. So in the chest x-ray, we will see a lot of radiolucency or a lot of blackness on the side of pneumothorax because there's going to be more air in the pleural space rather than on the actual lung. There's going to be a couple of consolidations and atelectasis because there's not much air that's on our lungs. Lung unit will collapse, so depending on where the pneumothorax is, that affected part will be collapsed. Depression of the diaphragm, because I said earlier we don't have much air in there, so it's going to be depressed because it's going to be more hyperinflated. The thoracic area is going to be more hyperinflated because of the air that's trapped on the pleural space. And there's going to be a mediastinal shift towards the unaffected side for dense pneumothorax. Excuse me. So basically your trachea and your heart and your collapsed lung is going to shift on the side that is not affected. So you're going to have a shift of your mediastinal. So, have anything to say besides that? Yeah, so there's also going to be a displaced heart sound because your heart is going to be moved. And just to add on to that as well, because the heart is being moved, there's going to be more heart problems such as pneumoperitoneum or cardiac tamponade or something like that because the heart is being compressed, so the heart pumps smaller. It's going to be more decrease in venous return, and then your cardiac output and all is going to be more decreased. So there's potential rupture on your heart as well. That's why you could have a pneumoperitoneum. Our roles as a respiratory therapist is we could monitor the saturations and the vital signs. We could continuously listen to the breath sound, see if there's any changes, see if there's gonna be movement of air, and then in the affected side. We could also see if the see the X-ray and see if the pneumothorax has been resolved from the treatments that we did. Excuse me. We could monitor the oxygen flow, monitor the ventilator, make sure that we don't cause more pneumothorax by having iatrogenic pneumothorax, make sure we watch our tidal volume, make sure that we watch our pressure, and then we could also make sure that they're in a good state. So we looking for alerts such as accessory muscle usage, because that will indicate that the patient is going to be more in distress, and that will sort of lead us to a conclusion that the patient might be having another pneumothorax, or the patient is still having a pneumothorax, or is the pneumothorax is not resolved yet. So we could also do a full body assessment. We could do a PFT test, ABG test, and we could do the respiratory medications if there's any order. That way we could help alleviate the pain. So that basically concludes the lecture for our pneumothorax. So I just want to go over also that in any emergent situations, if we need to, if there is a definite conclusion that the patient is having pneumothorax, we could do a needle decompression, and we could put it in the first and the second intercostals. Excuse me. And these are just some of the questions in here. So that's basically it. Thank you.